Welcome to the Fundamentals of Quality Improvement. This video aims to provide you with an introduction to quality improvement, or QI, why it's important, and Pennine Care's improvement methodology. There is an assessment following this video to ensure that you've understood the information. Please make sure that you've received this. You should also have received the Fundamentals of QI training guide. If you haven't, please contact improvement.penninecare@nhs.net. You can refer to the training guide throughout the video and also when you complete the assessment for further information and support. By the end of the video, you should have a better understanding of what QI is, know and understand the model for improvement, and Pennine Care's way of approaching this. You will also go on an example QI journey where we will detail the 4 key stages in improvement and highlight simple tools you can use at each stage. We'll also signpost you to further support and training that is available to you from here on. So let's start by introducing quality improvement. So what is QI? It has 2 elements. The first is quality and the second, improvement. It is important to know that it is greater than these 2 things and that it is more than just improving quality. The Care Quality Commission defines QI as the use of a systematic method to involve those closest to the issue, that's you, in finding solutions to a problem. To do this, we use consistent method and tools to identify and test ideas. It uses measurement to tell us if our changes are leading to an improvement. It is important to note that it involves everybody, and it's not the responsibility of one individual or team. We all need to work together to ensure the continuous improvement of our services and the organisation as a whole. So let's start with quality. What does quality mean to you? Pause the video for a moment and have a think about it. What do you think quality means to our patients? Would our healthcare professionals, doctors, corporate staff or board have a different view? It's safe to say there is no universally accepted definition of quality. However, in healthcare, there are 6 dimensions that are widely used. These were developed by the US Institute of Medicine and are used by the Institute of Healthcare Improvement, the IHI, the CQC and the World Health Organization. The care that we provide needs to be safe so that it minimises risks and harm to service users. Timely, so it happens when it needs to. Equitable, meaning it does not vary in quality based on personal characteristics. Effective, so it's evidence-based. Efficient, meaning it uses our resources in the best way possible and avoids waste. Person-centred, so it takes into account the preferences of individual service users, their cultures and communities. These dimensions were extended in 2013 to include sustainability. This is to ensure that we provide a service that can be maintained over time. Now let's look at the other half of quality improvement. You may have personally experienced this. While all changes do not lead to an improvement, all improvement requires change. So, why do we try to improve? It might be because of new evidence base. The outcome of a clinical audit or investigation or complaint may have highlighted the need for improvement. It may be due to a request from the Commissioner. Now that we know what quality improvement is, why is QI important to us? It's one of the 4 big ambitions for the Trust, for all staff to feel engaged and involved in improvement. Adopting this approach allows us to continuously improve and become better one day at a time. We also want to embed a culture of continuous improvement where everyone is skilled and empowered to innovate and improve. So let's learn about Pennine Care's way to improvement. We use the model for improvement. It's simple yet powerful. The model has 2 parts. 3 fundamental questions, which can be addressed in any order. These are, what are we trying to accomplish? How will we know that our changes will lead to an improvement? That is, how do we measure it? What change or changes would we like to introduce that will result in an improvement? Once we have answered those questions, we can use the Plan, Do, Study, Act, or Pdsa cycle to test changes in real work settings. We will be using the model for improvement later in our example journey, so you can see how this works in practice. More often than not, particularly in the NHS, we find ourselves facing a lot of issues with little knowledge about where to start. Our natural tendency is to implement and spread the first solution that comes to mind. Or sometimes we just introduce and implement things hoping it fixes something somewhere. If you ever find yourself in such a situation, consider using Pennine Care's Way to Improvement. It involves 4 simple steps. The first is to discover your issue. Is this the right issue, or is it just a symptom of the true issue? If you have lots of issues, start by acknowledging they exist. The second step is to define your aim. It's important to ensure that you place your efforts where most improvement can be made. For the issue that you pick, ask yourself, how will I know I have addressed it? The third step involves developing ideas that will help you meet your aim. It's also important to test your ideas to make sure they are fit for purpose. The fourth and last step involves delivering the right solution for the identified problem and ensuring that it is sustained. For the purpose of this video, we'll be using an issue to take you through the Model for Improvement and Pennine Care's 4 stages. So, what is our issue today? Our patients are staying in our service too long. Let's start our QI journey. As mentioned before, there are 4 stages. Stage 1 is discover, stage 2 is define, stage 3 is develop, and the final stage is deliver. Starting off with stage 1, discover. In this stage, we look at different sources of information to understand our issue. Is this the right issue? To do this, you can review your current data, if you have any, collect stakeholder views, do a root cause analysis to get to the bottom of it all. You don't have to use all these approaches, and most of the time one is enough. In terms of data, not everyone has data, and you don't always need it. If you wish to collect data to support your improvement, you can keep it as simple as a tally chart. Most of us have a wealth of existing data, which can be really helpful at this stage. So, how do we know the issue we are experiencing is actually an issue? Think about the example of our patients staying in our service too long. How do we know this is the case? Is there any information on Tableau that exists? Has this been highlighted through staff feedback around complexity of patients and caseloads? Once we've established that the issue needs to be dealt with, it is important to understand the root cause of it. Doing a root cause analysis means we address the issue, not the symptoms. One very simple tool for doing this is the 5 whys. It's easy to think about this as a small child asking you questions. Why? 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 In essence, you state the problem and ask why. Once you gather the response, you ask why again, and carry on until you reach the root cause. It may take less than 5 whys, and it could possibly take more than 5 if your issue is complicated. Applying this to our example issue of why patients are staying in our service too long, the first reason could be there is no criteria for discharge. If we ask why again, the response could be, well, there is a discharge criteria, but we don't follow it. Why is this, you may wonder? It could be due to a lack of understanding of the criteria. And why is that? Because of the poor local induction procedure. The poor local induction may be a root cause of this issue, but there may be other causes. If you find yourself stuck for ideas, here are some other areas to consider. Could your issue be due to a lack of communication? Are there any procedures, policies or processes creating this issue? Once we've discovered the root cause, we can move on to stage 2, which is define. In this stage, we answer the first of the questions in the Model for Improvement. What are we trying to accomplish? It is important to have an aim to help us identify a clear focus for what we are aiming to achieve. It is also important to ensure that we link our aim to the quality dimensions of healthcare that we mentioned earlier. When we set an aim, we must make it SMART: specific, measurable, achievable, realistic, and time-bound. In improvement, we recommend that your aim has 4 elements. What are we trying to achieve? By how much? By when? And for whom? We need to make sure that we do not focus on how we will fix the issue, as that comes later on. Going back to our example, if our patients are staying in our service too long, our aim statement could be, we want to reduce our length of stay, but that's not too smart, so let's add by how much and when. Say we want to reduce it to 28 days in the next 6 months. That's pretty smart, but it is missing one element: who will be affected by it. So let's say it's for patients on the Deming ward. Pulling this together, you would say, we will reduce the average length of stay to 28 days in the next 6 months for patients on Deming ward. And that's the end of stage 2. We can now move on. So, stage 3, developing our solutions. In this stage, we will be creating a theory of change model, which is basically a plan on a page, engaging with our stakeholders using a lift speech, and thinking about measurement to make sure we're on the right path. Let's start off with the theory of change. Like we said, this is like a model or a method to help us plan, implement, and evaluate change. It helps us to answer the third question in the model for improvement. What change can we make that will result in an improvement? This also helps to see all of your project on a page easily. The model we will be talking about will be a driver diagram. Some of you may have heard of it before. A driver diagram has our aim stated on the left-hand side. We have several drivers that help us to achieve the aim. These often tend to be system level, such as communication, training, policies, and so on. On the far right, we have our change ideas. These are the ideas we want to test and put in place in order to achieve our aim and address the issue. For our driver diagram, we will also have a section for stakeholders and one for our measures. When you are developing your change ideas, be creative. Think outside the box. You know that idea that you've been thinking about, jot it down. We'll be testing all our ideas out, so now is the time to find out if the idea works or not. It's great if it does, it's learning if it doesn't. Just make sure your idea addresses your aim or supports something that will solve your issue at the end. For our example issue, let's start by putting the aim we created in stage 2 at the far left. We will reduce the average length of stay to 28 days in the next 6 months for patients on Deming ward. Our change ideas for achieving our aim may be creating a leaflet with information about what the service offers, mapping out what resources within our organisation, local authority or third sector are currently available to us for discharging service users, reviewing our criteria for referral and discharge, or creating a new criteria if one doesn't already exist, or holding an away day for team building. Our drivers for this would be an information one, criteria, and one around staff. Drivers can be loosely created by looking at how we can group our change ideas. If we affect these areas through those change ideas, we will hopefully meet our aim and reduce the average length of stay. Moving on to other parts of our plan, let's look at stakeholders. So, what is a stakeholder? A stakeholder is anyone, a group or a person, who has an interest in the changes you're proposing, or could be potentially affected, or perceived to be affected by them. If you have problems identifying your stakeholders, one way would be to use the 6 C's. Again, these are prompts to help you think about the different people that can be affected. You may wish to get your stakeholders' input into your change ideas, or get them to offer some ideas to test as well. You can collect their input through different ways, including focus groups and listening events, patient stories, shadowing, feedback from colleagues, or even the complaints and compliments received. Going back to the plan on the page we've been creating, some of our stakeholders could be staff on the ward, the team leader, service manager, and of course, patients and their families. So why do we need to capture this and keep our stakeholders on board? At the minimum, for whatever change you might be thinking of, it's important to make sure you have your line manager's support. Tell them what you want to achieve and why you want to do it. Think about how your idea benefits the service or department, and more importantly, the patients and service users. If there are any strategic alignments for your changes, it can help in gaining support. You might be thinking, great, but how do I tell my stakeholders all this? Engagement is the key when it comes to stakeholders, so you need to be able to explain your idea quickly and clearly. One tool for doing this is the lift speech. This is like a sales pitch that summarises your project. It should be short and sweet, around 30 seconds. Make sure you include your aim and explain why it's important and what the impact would be. For our example problem, this is the lift speech. We want to improve the average length of stay in the next 6 months on our ward. Staff caseloads have been very high, leading to low staff morale, staff burnout, and an increase in staff sickness. This is also having an adverse effect on the care that we provide. Our patients tend to stay on our ward for 5 to 6 weeks. However, we currently have some patients that have been here for over 3 months. This not only affects the quality of life that people are leading, but causes dependency on our service. We need to think about the care we want for ourselves. Note how the elements of the lift speech are embedded in there. It states what we want to do, why it's important, and what the impact is as well. When you write your lift speech, make sure you practice it well. It may be 30 seconds, it may be shorter or longer. Don't worry, the more you practice, the more natural it will feel. Looking at the last part of our plan on a page, let's talk about measurement. This addresses the last question in the model for improvement. How do we know that the changes we will make are leading to an improvement? Measurement is a very important part of improvement because this will help you to understand if your changes are the right changes and are not adding work which leads to no improvement or even makes the current situation worse. As part of measurement, we need to identify what our measures are and also be able to understand the results. There are 3 types of measure that you need to be aware of when making a change: outcome, process, and balance. Your outcome measure tends to be linked to your aim. It tells you when you have reached your destination. You normally only have one of these. Next are your process measures. These are linked to your activities or change ideas. For example, if you never actually execute your change, you will never see the improvement you wish to see. Last but not least are your balancing measures. These are important as they check that another area or service is not being negatively affected by the changes that you bring in. Balancing measures can be positive as well, but they help keep the overall system in check. Going back to our example, we can now add our measures. The outcome measure would be the average length of stay, in days, so that we can see it's been reduced and that we've met our aim. One of our process measures could be the number of patients discharged under our new criteria. And the balancing measure could be the readmission rate. This would ensure that we are not discharging too early, causing an increase in readmissions. And with that final addition, we have our completed plan on a page that we can show to others and evaluate our changes from. Now that we have our change ideas, our lift speech and our measures in check, we can move on to the next stage. Stage 4, which is delivery of our change ideas or solutions. In this stage, we will be taking each of our change ideas and testing them, using the Plan, Do, Study, Act or Pdsa cycle. We'll also look at sustaining and spreading our changes, successes and learnings. So what is a Pdsa cycle? The cycle consists of 4 stages. The first is plan. This is where we set an aim for the change idea. This is different from our overall aim that we created in stage 2. This only relates to the change idea. We also think about any data we need to collect and make a prediction about what will happen when we do as we plan. The second stage is do. We carry out our plan and collect any data that we need. The third stage is study, where we look at what happened and compare it to our prediction. Finally, we act. We need to decide whether the change is not suitable, needs further tweaking, or it can be implemented. If the change needs further amendment, we can use the next cycle to do that. So why do we use Pdsa cycles? This is because these cycles are the scientific method made simple and easy. Because we're predicting what will happen, it enhances our learning, forces us to use measures, and gives us a clear direction to travel with each cycle. And because we're testing, it increases our belief that our change is the right way to do things. It can also help to decide which change is most effective and provide a sense check for how much improvement to expect. If we test our changes, it helps minimise resistance when we come to implement them. The principles for undertaking Pdsas are that they should pilot tests on a small scale. Think 1 clinician, 1 patient for your first test. You should collect data over time and use it to build your knowledge sequentially so that we move from all our potential solutions to solutions that actually work. For our second and third test cycles, we can increase the number of patients or clinicians or both. It's important to remember that there is no such thing as failure in improvement. If your prediction was not correct, it may be because the change wasn't as effective as we'd hoped. The change happened, but it just didn't lead to any improvement. Or maybe there was some local improvement, but that didn't impact on our aim. So-called failure is key to our learning process and helps us understand our system better. So, have you ever used a Pdsa cycle? You may think not. But every time you visit a DIY store and bought a slightly different or completely different shade of paint, you'll be testing and refining ideas as to what will work. Equally, if you decide to try a different route or a different time to leave for work or home, you're doing Pdsa cycles. You're predicting that you will get somewhere quicker and then testing that idea. So, for our example, let's take the first change idea from our plan on a page. Creating a leaflet detailing our service offer. Our first test may be to create a draft leaflet and agree it at the next team meeting. We predict that the leaflet will be fine and that no changes will be needed. We then actually do this and share the draft leaflet by email and then at the meeting. What we find is the format we've picked isn't favoured and everyone feels that a question and answer format would be more suitable. So we act on this and change our formatting to suit and then retest in cycle number 2. Our second test starts when we've reformatted our leaflet and we've shared it with patients for feedback. Our prediction is the same, that no changes will be needed. We ask some of our patients to check the leaflet, and we're told that the leaflet is good, but they'd also like some more information about useful helplines and websites, and we've used a few too many abbreviations. We can make these changes and then test this with a larger group of patients, or for longer. Once everyone is happy with the content, we can pass it to a communications team for branding and printing. And this is just 2 test cycles for one change. You'd have similar ones for each change that you test. We can then think about our data. By using measurement, we can track if our change has led to an improvement over time. In the example shown, you can see the change we introduced led to some improvement, but we're still a way to go to reach our aim. With an improvement, there are several tools to do this, but we understand that data isn't for everyone. We do have some intermediate level training if you're interested. You can also ask the information team or one of the improvement leads to support you, and we will try our best to help. And the last part of stage 4 is spread and sustain. As you may be able to guess, this isn't easy. But the good news is you already have a start. If you've engaged with your stakeholders and started testing ideas using Pdsas, you will have the evidence to support you in getting people on board. You should look to get support from senior leagues and colleagues as well. So how do we continue our good ideas? Think about spreading them through the intranet, through ourselves in the improvement team. If you use social media, you can use our Pennine QI hashtag, or through your own networks. Word of mouth is really important. Tell people around you about what you're doing. For sustainability, get people that have some faith in your changes to own them, possibly even test them. Engage with staff, share your learning, and involve people in developing and testing your ideas. Importantly, if possible, don't rely on just one person. So, to finish off, let's do a summary of what we've discussed in this video. We've talked about quality improvement and the model for improvement. We've also taken you through Pennine Care's 4 stages: discover, define, develop, and deliver. We've talked about the tools you can use in each of the stages. You're not limited to these, and if you wish to learn about other tools, you can contact the improvement team or access our intermediate level of training. Again, you should have been provided with a copy of the training guide with this video. You can refer to it at any time. There is a copy of the templates of the tools discussed in this video at the end of the booklet, which you can use. If you want any further improvement training, we have 2 tiers of training at intermediate level you can access: the QI Champions Programme and the QI Bite-Size modules. The QI Champions Programme will take you through an improvement project over 3 full workshop days, spread over 3 months. You'll have a QI lead attached to you throughout the programme that will support you between the 3 days and afterwards if needed. You can book yourself onto the course through the intranet. The Bite-Size modules cover specific tools. These are delivered on an as and when needed basis, so let us know when we can come and deliver it to you or to your team. We can also provide coaching support through the local improvement leads. If you do not know who to contact, just drop us an email on improvement.penninecare@nhs.net or call 0161 716 3468. Last but not least, the assessment. You should have received a copy of the assessment with this video alongside the training guide. Hopefully you've gained all the knowledge you need to complete the assessment from this video. Once you've completed the assessment form, you'll need to email it to us, and provided you've understood the material, we will add this competency to your ESR record and send you your certificate. If you have any questions or queries, please just get in touch. And that brings us to the end of this video. Thank you for listening.